my screen now?
Yes, looks perfect.
Okay. Let me start the timer here. Okay, so thank you for being with me today. I want to go over the uterine mesenchymal tumors. I will limit my discussion to things that are more clinically relevant rather than esoteric. This presentation lives in the, or will live in the GYN library on the shared Google Drive. So I want it to be more like a handout that can help you when you prepare for your boards, for example, or if you have a case and you want to explore what immunostains I use or what are the criteria. I hope you find this presentation on Google Drive as a good resource for you to understand the classification, recognize diagnostic clues, or build a differential diagnosis, or describe ancillary studies, molecular immunohistochemistry. I hope you find it useful for your study and for your practice. All right, so the challenges when we talk about mesenchymal tumors of the uterus is that they all are the same. They all, at least clinically, they appear the same. You receive them with the history of abnormal uterine bleeding, and the imaging showed a mass, and it looks like a fibroid thing. They all come with that scenario. Yes, the great majority of them are going to be leiomyomas, but how can you tease out the ones that are not really just leiomyomas? Let us start from the beginning. The WHO classification, this is the most relevant or the most recent classification. Smooth muscle tumors, leiomyomas, leiomyoma variants, intravenous leiomyomatosis, leiomyosarcoma. Endometrial stromal tumors, the absolute benign end is endometrial stromal nodule, and then you have the low grade and the high grade ESS. Sometimes we can't even make that distinction, so we just call it undifferentiated sarcoma. There are other miscellaneous tumors, like the uterine tumor resembling ovarian six-cord tumor, a very awkward, long name, but that's the best we could do. Picomas, IMTs, inflammatory myofibroblastic tumors, and there are other non-specific uterine tumors, but any sarcoma, basically, you can see in the uterus. And of course, there is the mixed epithelial mesenchymal tumors. And I remind you that the stroma, the malignant stroma that you see in adenosarcoma is nothing but a low-grade ESS with some entrapped benign glands in it. So basically, these are the same tumors. So there is no one silver bullet that you can use to navigate your way through these tumors. But if you signed out with me, you will notice that I rely a lot on the clinical presentation, imaging. Hopefully they did an MRI, gross description, and the microscopic description. So I want to emphasize that the approach to mesenchymal tumors of the uterus really requires that you try as much as possible, combine all these four modalities together so you can be safe. Try to find the bullets in these things. Let us start with the smooth muscle tumors. From the beginning, leiomyomas, we all have seen them. You've seen one, you've seen them all. They can come in all sorts of locations. I'm not going to waste your time with that. Some of them may even be protruding through the cervix, and then you need to differentiate them from primary cervical mass. Microscopically, they vary a lot. You can have nice palisading, nice verrucate bodies, some hyalinization, some calcification, some ossification. But the one feature that you see in all leiomyomas is the thick-walled muscular blood vessels. And I hope that this stays with you through this presentation. Just always look for the thick-walled blood vessels. When you find mast cells, it's great. Mast cells, they are reported here. Here they are. You can, if you can see them, you can do CD117. But mast cells are kind of a soft criterion to help you calm yourself, because they are usually present in leiomyomas and not leiomyosarcomas. Sometimes you get this scenario of a lung lesion in a patient that was diagnosed before as leiomyoma. And I don't like it when pathologists say leiomyoma with atypical features. That is not a diagnosis we saw in the WHO classification. Gynecologists and gyno-oncologists know how to deal with classifications from the WHO. If you say leiomyoma with atypical features just to comfort yourself or make good about yourself or cover yourself, that doesn't help the patient, because the patient is going to come back with a lung nodule. And I hope you don't really go through that. And then you beat yourself. You say, why did I say atypical lesion, atypical features? I should have called it what it is, which is leiomyosarcoma. So I hope we can go navigate our way through this maze today. Sometimes when there is hydropic degeneration, you start to see areas of edema, cystic changes, effacement of the classic compact fascicular appearance that you are used to, and therefore you get areas of lower cellularity. But the problem with that is that you start to see mitotic figures, and then now you start to worry. If you have a good colleague in imaging, they will tell you that they see cystic changes, so they can guide you. And we are fortunate here that we have radiologists who are interested in female genital tract. So they will tell you, I see a fibroid, but I also see a cystic component to that fibroid. So you prepare yourself. Grossly, it will look something like this. We all have seen these tumors. When it looks like fibroid, it presents like fibroid, but it is so cystic. What am I going to do with that? Well, you shouldn't really trouble yourself much. You expect to see those spaces. It's kind of like soaked in water. There's so much water on the section. And as I said, you start to see mitosis. That is going to be problematic for you. But if you can catch some mast cells by H&E or by immunohistochemistry, it can help you, again, calm yourself. And remember, none of the features we see in, or we will talk about in leiomyosarcoma, we see it here. So there is no need for you to start saying things like atypical features and stuff like that. That's just hydropic degeneration in a leiomyoma. So with hydropic degeneration, I know there is going to be nuclear pleomorphism. There is going to be increased mitosis, but calm down, you expect that. So the clues in this particular case would be the history. Typically, this is a long-standing tumor. Imaging, they will tell you that the size is large. They will tell you that there are degenerative changes. Microscopically, as I said, you may find increased mitosis, and you may find some areas of water, hydropic degeneration. But the one thing you will not see is tumor type necrosis. Then there's this other variant that is called highly cellular leiomyoma. The problem with that tumor is that it has some sort of irregular borders, like there is pseudo-infiltration. You will have high cellularity, so now your heart rate is going fast. You start to get anxious. The cells are small, they are packed. What am I going to do? And I will start to see maybe mitosis, or convince myself that there are mitosis. Again, you need to calm down. This is one case from this department, and you can see it was actually hemorrhagic, and it is concerning. Grossly, it looks infiltrative. If I just show you this gross and ask you, what do you think? I think the majority of us will be concerned. Could this be a leiomyosarcoma, or could this be an endometrial stromal sarcoma? But microscopically, it looked like this. Again, it's not endometrial stromal sarcoma. Why? Because of the thick-walled blood vessels. Again, I want to emphasize, the thick-walled blood vessels that differentiate myometrial tumors from endometrial stromal tumors. Yes, it is blue. Yes, it is cellular. Do I really see tumor necrosis? Not really. Do I see mitosis? Maybe, but not much. So I want to talk about what we call ischemic necrosis versus tumor necrosis. Ischemic necrosis, as Dr. Klein always reminds us, it wipes out the tissue, like the whole area is just necrotic, including the blood vessels. Look at on the right here. Even the blood vessel is necrotic. What can initiate that process? That is ischemia. So ischemic necrosis, the entire tissue is wiped out, including the blood vessels, and the transition from the necrotic to the cellular area is gradual. You see some cells and less cells and less cells and then no cells. Unlike tumor necrosis, which preserves blood vessels, so the cells around the blood vessel will be viable. And when you put a blood vessel here and a blood vessel there, between them you got necrosis. It looks like a map. So that is what we call geographic necrosis. Look at this again, geographic necrosis, and then you get some retained malignant cells about around the blood vessel. The transition from the necrosis to the cellular area is abrupt rather than the gradual that we saw. So these are kind of helpful features. When you see necrosis, you can convince yourself, am I looking at tumor necrosis? In other words, is this going to be a bad tumor, leiomyosarcoma? Or am I just looking at ischemic necrosis as a degenerated leiomyoma? Maybe it is cellular leiomyoma with degeneration. Some of the highly cellular leiomyomas may even look like this. What is so special in this case? And I want to raise your sensitivity to this appearance. When you start to see slit-like vascular spaces like that, slit-like vascular spaces, and the tumor is growing as in tongues, like tongues within the vascular space. If you ask yourself, is this truly a vascular space, or is it a degenerative area? You can do ERG or CD31. You can see here that this tongue here is lined by or covered by endothelial cells. So this is what we call intravenous or intravascular leiomyoma. I think if you see this, you need to put this in your report, because the gyne-oncologists, at least in our institution here, are sensitive about this diagnosis. Remember, you received this as a fibroid, or you received this as part of a hysterectomy with bilateral salpingectomy in a 42-year-old patient. So most likely they kept the ovaries behind, but when thinking that it was just going to be a fibroid. But when you put this in your report, I think there is intravenous growth. They will say, no, maybe I shouldn't leave the ovaries in this patient. Maybe I should go back and remove the ovaries, because the continuous, if some of these tongues escaped from the uterus, then they may migrate to other areas, as in lung, for example. And then if she continues to have her ovaries, if she continues to have her estrogen, maybe that will stimulate the remaining fibers to become leiomyosarcoma. So they will go back and do the oophorectomy if the oophorectomy was not done. So that is the significance of including this in your report. So again, highly cellular leiomyoma, be careful, the borders may be irregular, it is highly cellular, it may throw you in a panic attack for leiomyosarcoma. But if you follow the principles, if you follow the clues about why this is just pseudo-infiltration, there is no actual tumor necrosis, then you are safe and you will call it what it really is. One of the problems we have constantly in GYN pathology is that now they are putting progesterone in water. I always say it's almost like every time a patient has an abnormal bleeding, they put a Mirena IUD. So most of the specimens we receive after progesterone stimulation. And I need to be aware of how progesterone affects fibroid. I will see hemorrhage, I will see edema, I will see myxoid change. I will even see some vascular changes. Okay, I can see hypercellularity. Nuclear pleomorphism, even increased mitosis. Okay, now I started to say the bad words. Now I am getting uncomfortable with this. So if I didn't know that the patient has progesterone, I may start panicking about this case. And we all received these specimens when the patient was diagnosed as fibroid, and then they do a mercilation or curettage, and you end up having fragments like this. Are they scary or what? Because some fragments are cellular, some fragments are necrotic, right? And then you look at that. And then you start to say, well, what am I going to do? I even see a necrosis, mitosis here. What am I going to do? Maybe there is tumor necrosis. I only have a curettage. I don't have the tumor. So how am I going to decide whether this is just fibroid with progesterone, or is it a leiomyosarcoma? Or maybe I should just say leiomyoma with atypical features and let the chip fall wherever. No, don't do that. Well, if you look carefully, you will find other fragments that tells you that there is pseudodecidualization and atrophic glands. Oh, okay. So this patient has an IUD. Well, duh, if you just open the patient's chart, you will read in the chart that she has an IUD. Even worse, when you get a hysterectomy after a C-section, with C-section, the uterus will look very scary after gestation, because the progesterone of pregnancy makes the myometrium looks really, really scary. Look at this here. It is hypercellular, and you may even start to see necrosis, mitosis. But remember, the necrosis wipes out entire area, including blood vessels. So that is ischemic necrosis. And I don't know if you notice that the slide is pink. And this is not an error in my photography. Actually, C-section hysterectomy is always so pink because progesterone does this. It creates those areas of hyalinization, and the cells are large. They have cytoplasm. So the slide is pink. Leiomyosarcoma is not going to be pink, it's going to be blue. So I remind you that progesterone, you need to be aware, because you will see necrosis and you will see it might increase mitotic activity. But this actually is one of the easiest clues, because just open EPIC and read the chart. You will see that the patient was pregnant, or the patient is pregnant, or this is a C-section hysterectomy, or she has an IUD. Well, I know what IUD does to leiomyomas. Microscopically, you have that zonation. Some areas are cellular, some areas are not, and you will see progesterone effect in the endometrium. And then we have the FH deficient leiomyoma. The FH deficient leiomyoma, it has certain characteristics. It has hemangiopericytoma-like thin-walled branching blood vessels. It has increased cellularity. It has multinucleation, atypical nuclei, and it has prominent nucleoli, almost like inclusion. But again, it has absent tumor necrosis. Look at this. You can look at this and say, what's the big deal? It looks like just any other leiomyoma. And maybe you are right. But if you look carefully, you start to see how these blood vessels don't look like the ones I usually see in leiomyomas, do they? They are thin walled, they are slit-like, they are branching. It's almost like a hemangiopericytoma. And you start, if you get high, God forbid, if you get high power, you will start to see this. When you sign out with me, you notice I don't like high power because high power makes everything looks ugly. But I think this is one time when you really need high power to appreciate how atypical these nuclei are. They really are atypical. You start to get some even nuclear inclusions here, multinucleation. This looks really scary. And I don't know, I honestly don't know what we used to call them before the entity of FH deficient leiomyoma was described. I bet you we just went low power and just called them leiomyoma. And what's the big deal? Why do I need to say it's FH? We will talk about that. Again, remember, this is a young patient. And the slide is a little bit pink, but she wasn't pregnant really. And when you get high power, you start to see atypical nuclei. Look at this. Look at this inclusion-like nucleolus here. It's almost like a bull's eye with a space around it. That's not normal. That I should wake up and smell the coffee now. Something is happening. I have some cytoplasmic pink areas, and I have very, very atypical nuclei and multinucleation. I think I need to recognize this, and I need to mention it with the inclusions. And look at this bull's eye here, very, very prominent nucleolus, very atypical nuclei. And if you do FH, you will see that FH is lost. Now we have the antibody. You will see it retained in the neighboring myometrium, but the actual tumor cells are negative because they are lost. And the significance of this thing is that this patient may have the hereditary leiomyomatosis renal cell carcinoma syndrome. May not. Well, we know that this syndrome is a germline FH mutation, that they will get these leiomyomas. But again, most of the FH deficient leiomyomas we get is just a sporadic mutation, and it's not germline. But I think if you have it, if you see it, if you recognize it, you need to mention it in your report. And this is the standard, this is the smart phrase we have to put in a comment to let them know. Sometimes they tell you, yeah, we know her aunt had renal cell carcinoma and her mother has leiomyosarcoma. We know. Sometimes they don't know, and that will be a lifesaver for this patient. So she needs to be tested for germline, and she needs to be put on the protocol for observation. So with FH deficient, it is an important entity to recognize. You will have increased cellularity, you will have nuclear atypia, but you don't have tumor necrosis, and you don't usually have the mitosis. And thank God we have the immunostain that can help us close that loop. Clinically, you may actually get the family history of the syndrome, and those patients, as I said, usually are younger patients. You get it from low power. You can pick the vascular pattern is unusual. There are no thick walled blood vessels. What is going on? You get high power and you start to see the atypical nuclei, and the light bulb should go off in your head and say, well, maybe I should consider FH deficient leiomyoma. The other entity I want to talk about is the disseminated peritoneal leiomyomatosis. It is characteristically on the microscope. I noticed that the interlacing fascicles are short. I will show you some examples of that. You know how leiomyoma, you are used to long fibers going right and left in every direction. In this particular entity, the fibers are short. And you may find rare mitosis, but these are usually well circumscribed, non-infiltrative nodules. And you will see them outside the uterus. oh my God, outside the uterus. That is scary, especially if the patient also has leiomyoma. So what am I going to do? You are presenting me with a patient who has a leiomyoma. And of course, I can convince myself that it has atypical features because if you have high power, you will find some atypical nuclei. And then you are giving me peritoneal biopsies with tumors that look the same. What am I going to call it? Is that a leiomyosarcoma that metastasized, or what am I going to do? What am I going to do? So that can be a problem for you if you didn't know that this was the diagnosis. Again, the good news is that our radiologists here actually are very good in picking up that, and they tell you, I see these nodules, and they look more like peritoneal disseminated peritoneal myomatosis. Look at the nodules, and the nodules are well circumscribed, as I said. But you see how, yes, we have the thick-walled blood vessels, but somehow the nodules are shorter. Do you see that, or am I imagining? Like even on a low power here, this is not the usual appearance of a leiomyoma. The fibers are shorter. It's almost like nodular. Look at this here. The shorter fibers gives it a vague nodular appearance. And here is even on high power, you can see almost nodular appearance. Again, high power, you can see the thick-walled blood vessels with the nodularity and the short fascicles. This is a problem case that Dr. Klein donated to this collection, because as Dr. Klein was looking at this case, she started to see areas that looked like this. What's wrong here? What's wrong in this picture?
Infiltration.
Yeah, it's going between the fat. So, well, wait a minute. You told me that the margin should be well circumscribed. What am I going to do when it is infiltrating the fat like this? Well, yeah, it is well circumscribed here, but it is infiltrating the fat here. So what we did with that case is that we mentioned this in the report. We said that, yes, this is peritoneal disseminated leiomyomatosis. We know that's what it is, but there were areas of infiltration. Maybe this patient needs closer follow-up, just watch out for her. And I think that's what they did to that patient. And of course, there is the entity of lipoleiomyoma. People like to talk about it. I don't know why. It sounds, I guess it sounds sexy, or it looks sexy. I don't know. But the only thing I want to mention about it is that lipoleiomyoma is a distinct entity that is usually pedunculated to the outside. So it is subserosal, but it is pedunculated outside. So usually the radiologist will think this looks like an ovarian mass. We get those as ovarian mass, and then you look at it and say, what am I going to do with this? It looks like a leiomyoma. It's just a leiomyoma with a lot of fat in it. And because of the fat, now the pattern, the fascicular pattern gets disrupted, and then that creates a problem for you. Well, again, good news is that the imaging will tell you that, look at, this is outside the uterus. Here's the uterus, and the mass is coming polypoid to the outside. In this case here, they said, well, it looks like, is it ovarian, or I don't know, like, when you get that history or you read that in the radiology, the MRI report, again, the bulb, your antenna goes up and the bulb goes off. You say, well, I know what I'm going to have. I'm going to have this. This looks like a lipoma, honestly. I mean, this looks like a lipoma, but it was attached to the uterus. So what am I going to call it? Well, some areas are muscular, and then the muscle is infiltrated by fat. Some areas are just pure fat. And as you can see here, so this is a lipoleiomyoma. If you If you like brown stains, you can do Desmond just to comfort yourself and convince yourself that, yeah, okay, calm down. These fibers are actually muscular, and therefore this is a lipoleiomyoma. And then we have the entity called leiomyoma with bizarre nuclei. This is another scary tumor because the nuclei are bizarre. By the definition, they are atypical nuclei, and it may get rhabdoid a little bit. The nuclei are pleomorphic and smudged chromatin. I think they are smudged chromatin because they are dying. I think this is a degenerative process in the leiomyoma. Why am I saying this? Because they don't have mitosis. Like, the tumor is not proliferating. The tumor, if anything, is dying. I admit it looks really scary, right? Like, if I show you this and I say, what do you think of this uterine tumor? You say, I think this is a leiomyosarcoma. Interestingly, leiomyosarcoma, you may struggle to find atypical nuclei like this. But when the field is all atypical nuclei, it's almost like too good to be true. When I see this, I just laugh because it looks like a leiomyoma with bizarre nuclei. So the clue here is that you have pleomorphic nuclei in the absence of mitosis. And then, of course, Dr. Zhang and the team and Aisha, thank you, Aisha, for giving us this picture. This is one of the abstracts that Aisha submitted for the USCAP this year. Look at this leiomyoma with bizarre nuclei. Microscopically, it looks the same like every other leiomyoma with bizarre nuclei. It's really small. It's like, how big was it? Like, it was 3 millimeters or something. But guess what? It was P16 positive, and it lost RB1 expression. So these are features of leiomyosarcoma. Are you going to call this leiomyosarcoma? We didn't call it leiomyosarcoma, but maybe there are some types of leiomyoma with bizarre nuclei that are on their way of becoming leiomyosarcoma. I don't know. But as the WHO's classification stands today, I don't think we should call this leiomyosarcoma. You will call it leiomyoma with bizarre nuclei. If you want to put this immunostain in the comment and say, hopefully this will be published, Aisha, I hope you publish this in a paper. So it will be more than an abstract, so we can reference this paper and say, well, we don't know. I think we are in a transition in our understanding of this tumor, and maybe this is the smallest ever leiomyosarcoma diagnosed. We don't know. So these tumors are fleshy, which makes them a little bit scary, but as I said, smudged chromatin and low mitotic figures. So now here is the beast. Let us cut to the chase, and here is the beast. Here is the leiomyosarcoma. This is the nightmare. This is what we were all afraid to miss. You don't want to miss that. So I kept showing you entities that look like my leiomyosarcoma, and I said it is not leiomyosarcoma. Now this is the leiomyosarcoma, and this is how the leiomyosarcoma should look like and should be diagnosed. Number one is tumor necrosis, and that is, at least in our days, that was a classic board exam. They list all of these and say what would be the most important feature for diagnosing leiomyosarcoma, and the answer is always tumor necrosis. Yes, you will have mitosis. Yes, you will have nuclear pleomorphism. Yes, you will have tumor cellularity, and you may have infiltrative borders. But the one constant that was absent in all the entities we discussed before was tumor necrosis. So make sure you master that. You master the definition of tumor necrosis. And you need a certain number of mitosis. You need all of these things. But you also need a good radiologist who will tell you that this is a large mass, usually one mass, and it grew very fast. And they have certain features in the radiology, in the imaging literature, that they can tell you it looks like a leiomyosarcoma. One of the features is peripheral calcifications. They look for that, and the other feature is the decreased vascularity through the tumor, and then you get areas of necrosis. So they will tell you that it is most likely leiomyosarcoma, and you can see here it is how it is infiltrating the leiomytrium. It is so fleshy, it's so necrotic, it's falling apart. It is almost like brain material, and it is bulging. It is ugly. It is necrotic. And of course, I'm showing you the most classical example, but I admit that this is not an easy diagnosis because the criteria are kind of soft and confusing at best. But as I said, you will run into bizarre nuclei, but they are the minority, not the majority, as we saw in the previous case. So by low power here, you can see some bizarre nuclei here and there, but they are minority. And these cells are viable. These nuclei are viable, not dyskaryotic, as we saw in the leiomyoma with bizarre nuclei. A leiomyosarcoma can have anything. It can have fat, it can have liposarcoma, it can have rhabdomyosarcoma, it can do anything it wants to do. This is a relatively recent paper, a couple of years ago, talked about the molecular pattern, profile. If the tumor fulfills the microscopic criteria as we discussed here, just call it. Just call it. If it is borderline, you may find P53, ATRX useful. As we talked about RB1, they can push you a little bit. Sometimes they cannot push you, and you may get stuck. But I admit that in few cases we actually relied on the immunostains when the microscopic criteria were not very helpful. But clinically, you want to look for certain clues. The patient's age. You are not going to diagnose a leiomyosarcoma in a patient younger than 35 or 40. You are just not going to do it. So if you consider that and just remember me saying that, don't do it. Don't diagnose leiomyosarcoma, no matter how scary the tumor looked like in a younger patient than 35 or 40. Notice the history, like they will tell you, oh, this tumor grew very fast. It was like, it wasn't that big last year, so it grew fast. Usually it's a single tumor. The size by imaging also, if your radiologist is interested in the texture, if they are up to date with the literature about how to assess tumors for leiomyosarcoma, it will help you. Grossly, you will see areas of hemorrhage, you will see necrosis, and microscopically, just look for tumor necrosis. Of course, everything else is important, as we said, but you want to see tumor necrosis. So now I finished the first category of myometrial sarcomas, and I'm going to shift to the next category, which is endometrial stromal tumors. Endometrial stromal tumors, you will see a tumor like this, cellular, it's blue, and you notice that you don't have the thick-walled blood vessels. So the native myometrium will have the thick-walled blood vessels, but the tumor itself will not have thick-walled blood vessels. If you look carefully, you will see few mitosis here and there. But if the tumor is, I hope you can appreciate that it is bluer. The slide is bluer than the leiomyosarcoma, or bluer than the myometrial tumors. The problem is when you get this as a biopsy. So if this was, let us say this was an endometrial curettage, and you have this, what are you going to call this? Of course, you are not expecting this. This is a patient with bleeding, 65-year-old with bleeding and blah, 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 and they do a biopsy and you see this. You want to call this carcinoma? Of course, you want to call this poorly differentiated carcinoma, and then you go down the road of serous carcinoma, and of course you will do P53, blah, 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 and then you get stuck because you fail to recognize that the tumor could be mesenchymal. If it is mesenchymal, what is it gonna be? I admit it looks very epithelioid too, right? Endometrial ESS could be very epithelioid. And here is an example of the tumor that was actually a recurrence. A tumor was called fibroid, and whatever happened to the patient, and now the patient comes back with pericervical tissue, and this is the biopsy from the pericervical tissue. And then the pathologist did CD10, and it was positive, and it looked and it smelled like low-grade ESS. When it is a pelvic mass, you know, you receive the pelvic mass, and it was either in a hysterectomy or in a myomectomy, and you want to diagnose a fibroid or you want to diagnose a leiomyosarcoma. Hold on, I tell you, stop. Where are the thick-walled blood vessels? If you can't see thick-walled blood vessels, then maybe, again, you should now consider ESS rather than a myometrial tumor. Yes, it looks epithelioid. Yeah, we have mitosis. Yeah. And that's how an ESS should look like. By immunohistochemistry, a low-grade ESS will be CD10 positive. And if you do Desmond and SMA, usually they are negative. You may get confused because the tumor is infiltrating the myometrium, so you actually get staining in the native myometrium, but the tumor itself typically is negative. Low-grade ESS typically infiltrates the myometrium in finger-like projections. Look at that, tongue-like. So this appearance here where you see blue areas between pink areas, that is classic for low-grade ESS. That was a frozen section. And low-grade ESS is notorious for vascular infiltration, and you have to report that because this is another case of Dr. Klein, and this is a lymph node when they did the lymphadenectomy, and there was this nodule here, like, what's going on here? And by CD10, it was positive. So she called that, it's not the same case, by the way, but I'm just trying to print in your heads the notion that low-grade ESS is notorious for invading lymphatics and is notorious for lymph node metastases. But on high power, I like this a lot because I find this as the easiest clue. Those pink fibers between malignant cells, these are called collagen plaques. So the first clue was the absence of thick-walled blood vessels. And then now, okay, I'm considering low-grade ESS high power. Yes, I see mitosis, but I also do see the collagen plaques. The collagen plaques, look at this picture. It's just beautiful, because it helps me with the diagnosis of low-grade ESS. You want to do stains? Here are the stains, the classic pattern. Usually they are ER positive, they could be PR positive. And to differentiate it with high-grade ESS, CD kit or CD117 is usually negative. So this here is to differentiate it from high-grade tumors, and this here is to differentiate it from leiomyosarcoma. But the classic pattern of low-grade ESS would look like that. And I like to put them next to each other. So on the right here, you have a low-grade ESS. On the left, you have what we called highly cellular leiomyoma. Okay, so how am I going to differentiate the two? Again, look at the collagen plaques. Of course, if you want to do CD10, you can do CD10, but you wanna be able to at least have a conviction in your head that I am dealing with ESS, not leiomyoma, even though they look really very similar. But the collagen plaques are really helpful. So low-grade ESS, typically you have blue islands in tongue-like fashion between the myometrium. You have prominent collagen plaques. I cannot emphasize this enough. I cannot tell you how many times this was a lifesaver for me. It has small, thin-walled blood vessels. It does not have the thick-walled blood vessels. Yes, it may have focal smooth muscle differentiation, and that's why when you do Desmond and it comes back positive, and then you throw the towel and say, well, what am I going to do? And I will tell you, so why did you do Desmond in the first place? We know that it is going to be positive. That doesn't make it a leiomyoma. And of course, with the transfusion, JAS-F transfusion is notorious in these tumors, but sometimes we send them for transfusion, translocation, sorry, said transfusion, I'm sorry. JAS-F translocation, can be mostly in low-grade tumors, but sometimes we send them for FISH studies and it comes back positive, negative, but we still call it low-grade ESS. And here is a nice table to differentiate low-grade from high-grade ESS. High-grade ESS is notorious for, as I said, CD117 positivity. It is also notorious for cyclin D1, MDM2, and BCOR that can help you differentiate the two. The myogenic markers are only focal here, but they are more in the leiomyosarcoma. And as I showed you, the ATRX is lost in leiomyosarcoma, which would be helpful in your diagnosis. Just to differentiate these two, the translocations can help you with JAS-F in low grade, but WAY-WE is in high grade ESS. We cannot diagnose high-grade ESS without the known translocation, but you can diagnose low-grade without the JAS-F translocation. If you have none of these translocations, you can go ahead and call it, as I showed you in the classification of WHO, there is a sarcoma not otherwise classified. Quickly, some miscellaneous tumors from the WHO classification. You have the uterine tumor resembling ovarian 6-core tumor. These are usually well circumscribed, usually are benign. They do nothing about them. Cells are epithelioid. It looks unusual. It stains unusual. But if you know the entity, so here's a low power of what was sent to us as fibroid. It looks like a fibroid, but what is going on here? Like there are worms. It's almost like worms running through the slide. And you may have a mast cell or so, or you may have some inflammatory cells, but look at the, and you have a mitotic figure here, but look at the cords of epithelioid cells, some even rosettes, hence the name resembling ovarian 6-core tumor. And interestingly, these cells are positive for cytokeratin. I always find this fascinating. If you like CD10, I don't like CD10, but if you like it, you can do it. And you start to wonder whether it is ESS or not. Again, it is negative for Desmond, but it looks like a 6-core tumor. We had a case in this department where the tumor recurred. I think it was a Ridges or South Dale case. The tumor recurred. So not all of them are going to be benign. Another tumor is picomas. We started to see picomas, and they have a delicate capillary network, mixed spindle and epithelioid cells. And you have the classic immunostaining that can help you if you get stuck. But here is a tumor that again looks like a fibroid. You want to call it fibroid, but you can notice that cells have a different distribution around blood vessels, and that really doesn't look like fibroid. You have some large nuclei with really nuclear inclusions here, cytoplasmic inclusions. that really looks very, very different from a leiomyoma. So you get a tumor like this, you don't know what to do. You got this lecture. Is it FH? Is it PCOMA? What am I going to do? As I said, you have an immunostain, good, you can do HMB45, and that can help you. If you still think of FH, you can order FH. We have the antibody now. And this is a nice cheat sheet from the differentiating these entities that can be problematic by HME. But I found HMB45 and Melan-A really helpful. Again, PCOMA is confusing because cells can be epithelioid, and you have the nuclear pleomorphism and with the prominent cytoplasmic inclusions. And here are the clues. It may be hemorrhagic, may be fleshy, but again, if you have your head tuned right, you can get the diagnosis right. I think this is one of my last entities here, the inflammatory myofibroblastic tumor. Again, it's a well-circumscribed thing that looks like a fibroid, but it doesn't, because it has these alternating areas of hypercellularity and myxoid change. I think you really want to call this fibroid. You are tempted to call it fibroid, but take a deep breath, think a little bit. If it is just a fibroid, why does it have the myxoid change? And why does it have inflammatory cells? That's a clue. And maybe I should order ALK, and these tumors are positive for ALK, and that is the giveaway to call it IMT. So IMT is another benign tumor that looks like a fibroid, but it is notorious for ALK staining. My last slide here is about the mixed Mullerian tumors. You heard me talk about that a lot, mixed epithelial and mesenchymal. And you know, if both are benign, it's just a polyp. The epithelium is benign and the stroma is malignant, is an adenosarcoma. If they are both malignant, that would be a carcinosarcoma. So that's a simple table just to remind you of all biphasic tumors in the female genital tract. Carcinosarcomas, this tumor here is obviously aggressive. It is less than 5% of all tumors in postmenopausal patients. But I have this slide here to remind you that if you diagnose carcinosarcoma of the uterus, you have to do P53 and you have to do HER2, because this is how the algorithm works today. Because these patients will be put on Herceptin or some HER2 new drugs. All right, that concludes my presentation. I tried to go quickly to respect your time. As I said, this presentation lives in the GYN library on the shared Google Drive. I hope it will be a quick reference for you as you prepare for your board, or if you have a case and you really want to work it up and you want to look at the ancillary testing or where do you stand in the classification, I hope you can find this presentation useful as a quick reference for you. Thank you, guys.